And thank you very much, Madalena, for the easy transition, and thank you, Mr. Karamaki, for having us here today. It's an absolute pleasure to come back to my second favourite country other than where I'm from, New Zealand. So I wanted to talk about a real-world implementation of what Madalena was referring to here with regard to the efficiency metrics. But before we do so, there's been some incredible context given today, and I just want to bring that to the fore. We talked earlier, and it's been mentioned with other individuals, that we have a postcode lottery. If I needed to access cancer care today, am I absolutely sure the hospital I'm going to walk in to get that care would deliver what I require, and I would get the outcomes that I need? That's the question, and that's the lottery. The other thing is, as the head of cancer for one of the largest insurers in Europe, AXA, and I think that we're the 7th largest in the world, if I didn't know what optimal cancer care looked like. When I spoke to insurers, I spoke to hospitals, I spoke to doctors, I spoke to patients, we all had a slightly different perspective of what good means. And that gave us a problem. So if you're commissioning care and you commission responsibly and you use responsible use of your funds, you need to know how to direct that patient to a safe pair of hands. If you don't know that safe pair of hands, we're in trouble right from the start. And if we look at just some of the statistics that we've got here, and I coined a quote from one of the earlier speakers, where you live shouldn't determine if you live, and I added to that, or how you live. Because it's not just about getting cancer care, it's holistic cancer care and survivorship support to live or die well. And that's really important. So I won't go through these statistics, but variation, inefficiency, care worsening outcomes, unnecessary harm at the point of care, preventable mistakes, prescriptions outside of licensed indications are all drivers of inefficiency and all drivers of suboptimal care. So we said one of the problems we have is we don't have this consistency in when we talk about value. Value to whom? If you talk about value-based healthcare, V equals O over C. Value equals outcomes over cost. Whose value, whose outcomes, whose cost? And that's a question that we need to ask ourselves when we're looking at equitable value. No one stakeholder in the ecosystem should be eliciting value to the detriment of another stakeholder. That's called value synergy. It's not quite what we have at the moment. So what we did is we brought together a coalition, we called it the Health Value Alliance for a reason, health of the ecosystem, health of the patient first, value for all, and an alliance where we come together with a common set of goals to determine how to measure value. You can see some of the names here. Obviously, they're from multiple countries. So we've got America, we've got EU, we've got the UK all involved in this, and multi-stakeholders. And what we sought to do was to develop the Cancer Performance Indicator. We had the 137 measures that Madalena was referring to just before, which I was very fortunate to be co-author of that metrics report. And then we wanted to take that to the stakeholders and say, let's look at real-world application. Can you get this data in your electronic medical records from your patients, etc., today? So it has to be implementable. We don't want doctors having to fill in more data forms, etc., etc. That's a problem. And ultimately that we co-design that and co-agree that and come into an agreement with one another that we will implement these measures. And just to show that we've mapped our metrics report or our metrics base to the All.Can 8 core measures to show that this can be done, you can see some of the mapping that has gone here. But what we've done is we've distilled that down to 7 core value domains. And you'll see the value domains in the blue circle here. All of these relate to value. We start on the left with the gateway. Is this hospital fit for purpose? Do they have the right regulatory framework, etc. in place? Where do they sit with regard to compliance and various other things? Then there's the service requirements. How do they tell us that they deliver best of class clinical care? Where is their patient centricity? And what program do they have in place for patient improvement and quality improvement? The next is to measure what they say is actually real and that the patients tell us the same thing. And this is where the value flywheel comes into it and the CPI measures. I haven't put the CPI measures up on a slide because you wouldn't be able to read them. There's so many of them. There's about 83. But fundamentally, they distill down into these 7 core value domains. The exciting part, and what I really wanted to concentrate on today, is what can you do when you get that data? And this is about real-world value-based commissioning. I can see here 2 hospitals, provider A and B, with an aggregate across this spidergram or this radar chart. And you can see here in the black that this particular hospital isn't doing so well on its financials, which is one issue, but it's delivering better patient timelines, pathways, interventions, etc., compared to its peers. So is it the right value partner for me to be commissioning from, even though it's more expensive up front? And it doesn't need to be a hospital I'm referring to. It could be an intervention, it could be a pharmaceutical company, it could be a radiotherapy innovation, etc. Fundamentally, this is the principle of health technology assessment, if you want to look at it that way. When we get data, we can do snazzy stuff with these things. So look at the, I'm not going to touch on this slide, but it just shows how we're going to use bullet charts and funnel charts, etc., to understand things. But the very first principle of a data system is rubbish in equals rubbish out. The other thing is, if we look at Edward W. Denning, he says, without data, you're just another individual with an opinion. So let's get that data and get the opinion right so that we're informed. So this is quality in equals quality out. So we can see who in this organisation and what organisations across the network are delivering the right type of data and the quality data to enable us to give surety to the measures that we're giving. The next is to drill into the measures themselves. Once we've got the quality data, we can then go, okay, here's my dashboard on the left-hand side. This is my landing page. Underneath this, I can see whether my quality is right, where I'm sitting in the top 5 measures that I'm interested in, different measures for different stakeholders. And then I can go into each one of these measures and drill down and say, how are those sub-measures relating to my top measure? And what is the root cause of erosion of that measure? And last but not least, how do I sit with regard to my peers? And am I moving as a trend towards the red or the green with regard to outcomes and value? And that trend is really important. We want to look at who's doing well and how do you socialise that? And am I moving in the right direction if I put an intervention in place? Next, you can look at the correlations. So what was it that has occurred? And you won't be able to see the little step graph that I've got here, but it refers to access to care equals the total cost of life in 3 years. So we know there's an obvious correlation between how patients access care and also their quality of life, but also the cost of life. Remember that the system we're referring to relies on finance. So we need to ensure that this is a sustainable solution. The next is to take those correlations and drill down one more step and talk about value stories. So what about if we were to talk about how to explore the flow of patients across a pathway? How did that patient enter this pathway? Early, speedy, accurate diagnosis. That's number one. The right intervention at the right time for that individual that's appropriate for them. And did they come via their GP? Did they come via the National Healthcare Service, screening service, and what have you? And what hospital did they go to? And what effect did they have in the end of that pathway? This is looking at efficiencies of pathways and fragmentation. So any one of these swim lanes, if you want to look at it like that, can be jumped into and looked at in more detail, which is what we're effectively doing here on this slide. And I will spend just a little bit of time on this slide. Here's an intervention on the left-hand side that's looking at oncoplastic surgery, so reconstruction versus not. And it looks at 4 key measures at the top. I purposely didn't make these so big because we don't have the time. And then a bunch of quality assessments in regard to the patient. Within the cancer performance indicator, we have 37 standardised patient measures. Then we can look at across the different pairs. You can see a total ranking here. I would point to the right-hand side on the outside of the comparisons here. Let's look at the middle one. The middle top graph shows us that the black hospital is actually the most expensive in time, and most expensive in their costs. However, they're also the cheapest in 3 years' time. So when we're looking at risk modelling, value-based healthcare and those sort of things and commissioning and rationalising care, it's not appropriate just to look at the upfront cost. That drug, that intervention, that radiotherapy, the MRI LINAC, whatever it is we're looking at, might be more expensive. But does it elicit a better cost of life and time and therefore reduce the portfolio risk of that population? And that's starting to understand better, the better economics associated with these things. The last is to flip this model. The model that we use here, if you wanted to weight the different domains of the cancer performance indicator, we can weight them more towards the patient quality of life and use it as a quality of life indicator. If we look at the European Cancer Mission Project, they need to showcase that they've delivered improved quality of life to 3 million patients across Europe by the year 2027. How are they going to do that if they're not measuring across certain hospitals and certain beacon centres? So you can see the pivot that we can utilise with this data. The very last point I'll make with just a few seconds left is this call to action. We saw this all day today. We've been referring to closing the gap. If I can't measure hospitals, I can't commission responsibly. If I can't commission responsibly, I can't control cost and reinvest into where I'm getting the best value. So we've got what Magdalena was talking about before, the All.Can Efficiency Playbook that will give you a mechanism for assessing how you can bring 8 core measures into play. If you want to go even deeper and look at beacon centres, so we don't have a Greek hospital as a beacon centre, for example. We've got 500 other hospitals across the world, but not one in Greece yet. Then the Cancer Performance Indicator can show some global benchmarking in patient satisfaction, patient performance, outcomes, efficiency, and a bunch of other areas. And then the last thing that I would, as a call to action here, is adopt the measures, collaborate, and support the mission. Collaboration was key to this. If I go back to that last slide with all the different stakeholders involved, the hardest thing I've done in my career to date is to bring those collaborators to one table. Once we had them together, it wasn't so hard to get an agreement, actually, but it's getting different hospitals who are competing, different pharmaceutical companies who are competing, different policy and different entities who are competing with their policies to agree on a central mission and a common set of goals. So we can do it. We have done it. It's here waiting to be utilised, and that's the call to action. And I will stop there. Thank you.